So they're essentially choosing a public health insurance plan for their employees when they do that. They're choosing a public option. And in some research that I've been conducting along with collaborators here at UC Berkeley, we've been trying to track what the results have been of this experiment here in San Francisco that's been ongoing since the beginning of 2008. And there are a couple key features of what's happening that I think are important to bring out. First of all, among this 60,000 or so individuals who were adults who were uninsured in San Francisco as this was coming in, we're seeing something like 45,000 individuals now who have taken up Healthy San Francisco. Clearly, there's been some kind of a demand for this product. Even more importantly, among the firms in San Francisco, something like 20% of all firms have enrolled at least some of their employees in the Healthy San Francisco. They're paying into Healthy San Francisco on behalf of their employees. Again, there appears to be real demand for some kind of a public option. Okay. Now, we're very early into the process, and that may change. That's something that we're tracking over time. It's also the case that this public option is a very specific public option. It's only providing care really as sort of safety net type providers. Okay, it's not equivalent to going out and buying yourself a so-called Cadillac health insurance plan elsewhere, although it's relatively comprehensive in terms of the benefits that it provides, but it's just not making care available at a wide range of providers. If we look at who's actually signing up for the program, the vast majority of people who are signing up are under 200% of the federal poverty line in terms of their income. And these are mostly low-income people for whom this public option has been attractive. Now, there have been various estimates out there by people about how many people would sign up for some public option if it was offered. And those estimates range from 100 million people under some scenarios to the Congressional Budget Office estimates a much, much smaller number who would be attracted to the so-called public option. But our experience here in San Francisco suggests that it's going to be low-income people, for a public option such as San Francisco's, who are going to be particularly attracted to this option. Now, if we think about San Francisco and the health insurance marketplace, this is a very competitive health insurance marketplace. Now, when we think about the value of public options, we often think about maybe a state like Maine, where Senator Snow is from, where there's very little insurance competition. And if you were to bring in a public option, there's the potential that it could offer new choices to those individuals. When we think about San Francisco, where there's scads and scads of health insurance plans out there, yet people are choosing this public option if they're low income. That suggests to me that a public option which was targeted at low-income people may be a particularly attractive compromise in some sense. So let's think about this. So if we were to offer a public option which was limited to relatively low-income people, it would not have the larger effect that a lot of advocates of public options would like, but it would have the effect of serving a particular portion of the marketplace who's least well served by the current options out there. So if we look at the low-cost health insurance options out there today, they don't tend to be sort of these skinny provider networks that are only focusing on reimbursing at a set of public providers. They tend to have relatively broad provider networks in the Bay Area. They may have really high cost sharing, which aren't very appropriate for the low-income individuals, so they're not going to be very attractive in that sense. If we had a public plan, a public option, such as Healthy San Francisco, which was more broadly available, so it could have a relatively low premium, could have relatively comprehensive benefits with low cost sharing, but you're not going to be going to the world's best private neurosurgeon. You're going to be served by those providers in the public system for the most part. I think a lot of low-income individuals would choose to take up an option such as we've seen here in San Francisco. Now, we're making some trade-off in our public policy between equity. We'd like everyone to have access to the same plan regardless of their income, but we're trading that off with some kind of affordability metric given the reality of our current sort of political compromises that are available to us. So if we did this, this could be implemented very easily on a wide scale by essentially allowing people to buy into the Medicaid program in their home state. Say The current negotiations right now in Congress are talking about maybe expanding Medicaid eligibility up to 133% of the poverty line. How about we said if you're up to 200% of the poverty line, you're allowed to buy into Medicaid. And those subsidies that are being offered now for people to buy private plans through the healthcare exchange could be taken to this Medicaid plan, and individuals could use it to buy coverage through Medicaid, which according to the calculations that I've seen of the cost of providing Medicaid, the actuarially fair cost of providing Medicaid, is going to be much lower. So we would then have 50 laboratories for observing what happens when we allow real competition between the public and private options in 50 states around the country. Okay, let's see what happens. Let's see whether people choose this public option. It has a further benefit that I think fiscal conservatives should like, in that if indeed the public option is cheaper and people choose it, then that can reduce the amount of subsidies that we need to provide over time to individuals, rather than having to set our subsidy levels at the rate of some private plan and that private plan's cost growth over time. And so there's a lot to be said for that. As a further part of the compromise, we could say, well, let's say I'm a conservative and I don't think that Medicaid plans should be any good, and people certainly wouldn't want them. Well, let's just allow people who are currently given Medicaid to have the choice of taking the actuarial value of their current Medicaid policy, and they can bring this to a private provider if they want to take that subsidy to a private health insurer. If they don't like the way that their Medicaid program is run, because they don't think they can get access to the doctors that they want to get to because the reimbursement rates are so terrible, then they have the option of taking this to the private side, to a private insurer. Again, let's have this experiment. I don't think we're there yet for the larger country to buy into the idea of having a public option for everybody everywhere. But we could certainly experiment with it early on with low-income people, and I think that there's a lot of attractiveness to both sides of the aisle to doing something like this. So I will sort of leave you there with to ponder that possibility. Thank you for your attention.